pretty sure this is where we left off from last time. Um, yeah, from burns, and all the kinks are worked out. So we're looking at inhalation injury. I think we talked about this. Honestly, let's look at carbon monoxide poisoning. I think that's where we were last. So affinity to hemoglobin in your red blood cells. Hemoglobin is the red blood cells, and they contain oxygen. So if it's not oxygen that's connecting to those red blood cells to perfuse the rest of the body, it's going to be either carbon monoxide or even worse, cyanide. But no, not cyanide. It does a different thing. But definitely carbon monoxide. It replaces what would normally be used as a spot for the O2 molecules and attaches, so that way the O2 cannot transfer throughout the body because it has an ability to stick to those red blood cells 250 times greater than oxygen. So this creates a carboxyhemoglobin, odorless, tasteless gas. You get cherry red skin, only presents at levels around more than 40%. So it's going to be pretty far through the process before you even can detect it, at least through the skin. Multiple people feeling ill in the same residence or building, nausea, vomiting, if more than one person has the same, has the same symptom, then you know there's something wrong with the environment and not particularly that person themselves. Nausea, vomiting, headache, decreased level of consciousness, weakness, tachypnea, tachycardia. So carbon monoxide produces a false pulse oximetry reading, because it's detecting that there is oxygen connected to the hemoglobin. However, it can't tell whether it's oxygen or if it is carbon monoxide, because there's still oxygen molecules and carbon monoxide has oxygen molecules attached to them. So you need a specific carbon monoxide detector. I know we keep one in all the Chief trucks. High flow rate concentration oxygen is the best treatment for these patients, because even though it's hard for the oxygen to attach, we want to increase the percentage and chance that those hemoglobins attach to oxygen by just sending the body as much oxygen as possible. Acids and alkali burns. So acids, there's a burning process that lasts about 1 to 2 minutes with acids. It's going to cause coagulation. Much worse, we have alkalis. Alkalis, a burning process that lasts minutes to hours. It will cause a liquefaction necrosis. It's going to sit on the skin, burn through the skin, forming some weird soupy type concoction. And I think it's called saponification that does this. Yeah, like if you've ever seen the movie, what's the movie? Fight Club. Whenever he holds his wrist out and he pours the lye on it, that is the process of alkali, or turning fat into soap, saponification. So head, face, and neck trauma. So we have different types of amnesia. We have retrograde amnesia. This is no recall of events before the injury. Then we have antegrade amnesia as well. An inability to create new memories that exist after recovery of consciousness. You're going to have new memories. And then there's different types of head bleeds. We have subdural, we have subarachnoid, and epidural bleeding. Moving back up here to different fractures of the skull. So you have Lefort 1. It's going to stop pretty much kind of at the nose, at least halfway through. And then we have Lefort 2. You're going through the orbitals, and not through them, but just grazing the inside, but taking pretty much half of the nose off at that point. And then you have Lefort 3. Pretty much the whole front face minus the forehead is going to be split and detached at that point. So subdural head bleeds. We have a collection of blood that is between the dura and the arachnoid mater. Venous bleed, more common than epidural bleeds. Slow onset symptoms of nausea, vomiting, headache, decreased level of consciousness, coma, and there's going to be posturing. So you have posturing and you have flexion. Posturing is worse. or flexion is worse. I'm not sure actually between which one's worse and which one's not. But if they are flexed, so flexion, one of them is reaching up like this, almost like a vampire. It's like they're reaching towards the head itself. And then one of them is where the arms are like this, flexed all the way down as if, I don't even know what that would be, but it's not, this would be like vampire. I guess that's like Frankenstein, you'd say, but this is much worse. Which we had a patient that was doing this. I think it was the patient. We had a rollover patient on a giant lawnmower, rolled onto the patient, and they were fading in and out of not even consciousness, but they were yelling, and then they would go out, and then they would yell again, and it was like a repeating process every 15 seconds. And whenever we had her in the back of the ambulance and we were trying to get an IV and intubate and everything else, she kept either posturing or flexioning, and it was really hard because she kept jerking away at the same time. And subarachnoid, intracranial bleeding into the cerebral spinal fluid, sudden and severe headache, slow onset symptoms, worst headache of my life, dizziness, neck stiffness, unequal pupils, vomiting, seizures, and decreased level of consciousness. Increased intracranial pressure. This is Cushing's triad, a must know. Normal intracranial pressure ranges from 10 to 15 millimeters Hg or less. Not that much pressure. Treatment is going to be SpO2 of 94% and capnography monitoring of 35 to 40 millimeters Hg. Treatment, there's evidence of herniation. And then this is our triangle. So if we have bradycardia, we have a slow heart rate. If we have irregular respirations, it's not regular the way that they're breathing. And we also have a heightened systolic blood pressure. You're going to have Cushing's triad for that. Must know normal ICP range, SpO2 greater, 94, capnography. Yeah. Spinal cord injury. So we have axial loading. Vertical compression of the spine results in direct force that are sent down to the spinal column. This compression fracture or crushed vertebrae bodies, thoracic 12 to lumbar 2. Central cord syndrome, hyperextension, cervical injuries, and greater impairment of the upper extremities than of the lower extremities. You're going to have paralysis of the arms, sacral sparring, preservation of sensory and voluntary motor function of the perineum, buttocks, scrotum, or anus. Anterior cord syndrome, usually seen in flexion injuries, decreased sensation of pain and temperature below the level of lesion. Intact, light, touch, and position sensation, paralysis below the level of lesion. Brown-Séquard syndrome. Hemotransection of the spinal cord, there's going to be weakness or paralysis of the extremities on the same side. This is ipsilateral of the injury with loss of pain, temperature, sensation on the opposite side, which would be contralateral. So if we have hemitransection, simply put, means half the cord has been transected. An easy way to remember this is between Brown and Séquard. Think of the hyphen being a half transection between Brown and Séquard. Okay, so your thoracic 12 is right here. Your lumbar starts almost with the V shape. C7, V12. So we have different levels of principal dermatomes. So C5 is clavicles, C5, 6, and 7, lateral parts of the upper limbs. And then C8 through T1, medial sides of the upper limbs. C6 is the thumb, C6, 7, 8, that's the hand, rings and little fingers, C8, and T4 is at the level of the nipples. T10, level of umbilicus, inguinal or groin regions is going to be T12. And then anterior and inner surfaces of the lower limbs, L1, 2, 3, 4, 5, and S1 is all of this. L5 and S1 2, outer posterior sides of lower limbs. Lateral margin of the foot and little toe is going to be S1. S2, 3, and 4 is the perineum. All right, we're going to stop there.